Hi dentist, it's Peace Care. Let's learn pharmacology topic anti-diabetic drugs. In this we will discuss about parenteral as well as oral hypoglycemic drugs. This topic is very important as a 10-mark question comes from this in theory and it is very important according to Viva. Diabetes mellitus (DM). It is metabolic disorder characterized by hyperglycemia means increased blood glucose level, glucoseuria means glucose is secreted into urine, hyperlipidemia, negative nitrogen balance and sometimes ketonemia. In layman language we call it as patient को sugar है. Diabetes mellitus is majorly of two types. Type 1 which is also called as insulin dependent diabetes mellitus and type 2 also called as non-insulin dependent diabetes mellitus. In type 1 diabetes mellitus which is also called as juvenile onset diabetes mellitus, there is destruction of beta cell of islands of Langerhans in pancreas. It is majorly due to autoimmunity and there is antibodies against the beta cells which destroy the beta cells, and this is called as type 1A. In type 1B there is idiopathic means there is unknown cause for the destruction, but we see that there is no antibodies against beta cells. Type 2 also called as maturity onset diabetes mellitus. There is no loss or moderate reduction in beta cell mass, but the insulin in circulation is either normal, low or even in some cases it is high. There is no anti-beta cell antibodies and there is high degree of genetic predisposition. In this, the cells do not respond to the insulin. Usually for type 1 diabetes mellitus, we treat it with insulin supplements, and in case of type 2, it is treated with oral hypoglycemic agents. Insulin, it is hypoglycemic hormone synthesized in beta cells of islands of Langerhans in pancreas. It have two chains, A chain and B chain. Under basal condition, 1 unit insulin is secreted per hour by human pancreas and much larger quantity is secreted after every meal. Secretion of insulin from beta cells is regulated by chemical, hormonal and neuronal mechanisms. One by one we will discuss them, starting with hormonal. A number of hormones such as growth hormone, corticosteroid, thyroxine modify the insulin release in response to glucose. PGE has a seen to inhibit insulin release. More important are the intra-island pancreatic interactions between the hormones produced by different parts of island cell. The beta cell contribute to the core of the islands and are the most abundant cell type. Note that somatostatin inhibits release of both insulin and glucagon, whereas glucagon increases the release of insulin as well as somatostatin, and insulin inhibits glucagon secretion. Neural regulation. Islands are richly supplied by sympathetic and vagal nerves. Adrenergic alpha 2 receptors decreases insulin secretion, and adrenergic beta 2 stimulates increased insulin release, whereas cholinergic muscarinic activation by acetylcholine or vagus stimulation causes insulin secretion through IP3 DAG pathway, which increases intracellular calcium ions in the beta cells. 10-mark question comes as write preparations of insulin and explain in brief about mechanism of action of insulin and its adverse effects. Preparations of insulin is divided into 4 types according to duration of action as rapid acting, short acting, intermediate acting and long acting. Rapid acting are insulin lispro and insulin aspart. Short acting, regular soluble insulin. Intermediate acting, isofin insulin, insulin zinc suspension. Long acting, insulin garglin and insulin determire. Bovine insulin, it is obtained from beef. It differs from human insulin by 3 amino acids and it is highly antigenic. That means there are higher chances that the patient will develop hypersensitivity reaction. Pork insulin, it is obtained from pig and there is only one amino acid difference from the human insulin and it is less aminogenic. Human insulin, it is prepared either by enzymatic modification of pork insulin, also called as semi-synthetic human insulin, or by DNA recombinant technology. The human insulin is less antigenic. Mechanism of action of insulin. This is the flow chart, but we will discuss it by a diagram. In this is the receptor, also called as insulin receptor. It is present on the cell membrane. It is heterotetrameric glycoprotein containing 2 extracellular alpha and 2 transmembrane beta subunits. They are linked together by disulfide bonds and there is binding site for the insulin on alpha subunit and beta subunit have tyrosine protein kinase activity. When the insulin binds to the alpha subunit, there is phosphorylation of tyrosine residues and then of insulin receptor substrate proteins that are called as IRS1 and IRS2, which leads to cascades of phosphorylation and dephosphorylation, resulting in amplification of the signal or stimulation or inhibition of enzymes involved in rapid metabolic actions of insulin. There are certain second messengers like phosphatidyl inositol triphosphate, which mediates the action of insulin on metabolic enzyme. इंसुलिन ग्लूकोज का ट्रांसपोर्ट बढ़ा देता है अक्रॉस सेल मेम्ब्रेन बाय एटीपी डिपेंडेंट ट्रांसलोकेशन ऑफ ग्लूकोज ट्रांसपोर्टर GLUT4 by promoting its translocation to the cell membrane. Phosphorylation cascade increase the stimulation of the nucleus to form regulatory proteins which involve in cellular proliferation and cellular differentiation. Insulin receptor undergo internalization and then after degradation, or it can be recycled and again goes to the membrane. Actions of insulin. Carbohydrate metabolism. Insulin decreases the blood glucose level by inhibiting hepatic glyconeogenesis, glycolysis and lipolysis in adipose tissue. It promotes glycogenesis in muscles and liver and increases the rate of utilization of glucose. Protein metabolism. It promotes protein synthesis and inhibits protein breakdown. Fat metabolism. Insulin promotes the synthesis of free fatty acids and triglycerides and it inhibits lipolysis. It increases potassium entry into the cell and decreases urea output from the liver. Uses of insulin in juvenile diabetes. In non-insulin dependent diabetes, when diabetes is not controlled by diet or exercise, when there is failure of oral hypoglycemics, in stasis or surgery, infections, trauma, pregnancy or labor, gangrene of extremities, diabetic coma, also called as diabetic ketoacidosis. Adverse effects of insulin. Main is hypoglycemia. It is most common and dangerous condition because prolonged hypoglycemia causes permanent brain damage. Hypoglycemia occurs when a patient skips a meal and he does not skip his dose of insulin. Hypersensitivity. It is allergic reactions which are rare when we are using human insulin. There can be rashes, photosensitivity, purpura, transient leukopenia, rarely agranulocytosis. Local reactions. They can be swelling, erythema and stinging on the site of administration. And the main is lipodystrophy. It occurs at the site of injection after prolonged use. Non-specific side effects are nausea, vomiting, diarrhea or constipation, headache, paresthesia and weight gain, edema due to salt and water retention. Insulin resistance. It can be acute or chronic. There is development of acute insulin resistance due to stasis conditions such as trauma, infection, surgery or psychological stresses. In case of dental surgery, there develops a low grade acute insulin resistance which can be corrected by giving insulin. In case of chronic insulin resistance, it is mainly due to use of conventional brief or proc insulin. Such patient can be treated with highly purified newer insulins. This is a classification of oral antidiabetic drugs. It is of three types, as we can see this, that one is on the basis of enhancement of the insulin secretion, which further divides according to mechanism of action as KATP channel blockers and DPP4 inhibitors, and there is insulin to overcome insulin resistance, bigonides or PPAR gamma activators, and the other is alpha glucosidase inhibitors. 10 mark question comes as enumerate or write classification of oral antidiabetic drugs and explain in brief about mechanism of action of sulphonylureas. Sulphonylureas were the first oral hypoglycemic drugs to be introduced, and they have two generations. All the drugs have same mechanism of action, but they differ in potency and duration of action, whereas the second generation drugs are 100 times more potent than that of first generation. Mechanism of action: sulphonylureas directly act on the beta cells of the pancreas. They bind to the specific receptors. They are ATP sensitive potassium ion channel or KATP channels, which result in its blockage, and there is a reduction in potassium ion inside the cell resulting in depolarization, and it results into the influx of the calcium ions into the beta cells that leads to degranulation and releases or increases the stored insulin from the beta cells. Butamol is a sulphonylureas. They lower the blood glucose level in some diabetic and all the non-insulin dependent diabetic individuals. They are rapidly absorbed from the GIT and metabolized in liver and excreted in the urine. They cause increase in body weight. They are used in the treatment of maturity onset diabetes, insulin resistant diabetes, and diabetes insipidus. Sometimes a short note comes on metformin. They are the bigonides. They lower the blood glucose level only in diabetic individuals but not in the normal individuals. That's why they are also called as normoglycemic instead or rather than hypoglycemic. Bigonides do not interact with the beta cells to secrete insulin. Their mechanism of action is not clearly known but appears to be mediated by activation of AMP dependent protein kinase. Metformin primary action by which it lowers the blood glucose level is suppresses hepatic gluconeogenesis and glucose output. It have advantages over the other as it has the potential to prevent microvascular as well as macrovascular complications, which are the major risk of diabetes. It lowers the risk of hypoglycemia and it promotes weight reduction. They are used in obese mild diabetes and non-diabetic obese patients. Miglitol is a alpha glucosidase inhibitor. It is smaller molecule than carbose and it is a stronger inhibitor for sucrose. The potency of the alpha glucosidase are all same. The absorption of miglitol is substantial but variable. The absorbed drug is excreted by the kidney and there is no systemic toxicity is known till now. The dose we prefer is 25 to 100 mg TDS at the beginning of each meal. This is the flow chart of management approaches in diabetic mellitus. Very rarely a question comes as compare between insulin and sulphonylureas, in which you will describe about diabetes mellitus and its type. Then after you will give the difference, as insulin is used in type 1 diabetes and sulphonylureas in type 2. Then you will explain some of these points as insulin is used in the therapy of diabetic coma and some other points. This is all. Thanks. Make sure to share the knowledge with your friends. Keep supporting.